Good afternoon, everybody.
Good afternoon.
Okay, how do we determine what CBD products are best for treatment of different symptoms? Example, anxiety, pain, nausea. And do you recommend products with or without THC best treatment?
Yes.
And that's for Dave.
I think, unfortunately, we don't have any data yet. So what you're really tied to is patient experience. Our patients seem to prefer products with low THC, so that the euphoria from the THC doesn't interfere with their condition. So that's what our patients are using.
I have a question for that, but I'm sure people are thinking. When you say low THC, is that a 5 milligram, a 10 milligram? What's considered low?
It's more percentages,
Okay.
and it's down in the 9 or 10% range is low THC product. And the higher ones are at our dispensary, because we're medicinal, is in the 28, 29%.
Okay.
THC. And as I said in my talk, some people are really escalating THC. That's part of the concern.
Okay, thank you. Where did Dr. Maitland go? Okay, we're going to pick up another question. I have Chiari and Syringomyelia. My biggest fear is that I could pass it on to a child. Is research being done to see if there is a connection? Dr. Maher, you want to take that?
Sure. Well, we know that children of patients with Chiari do have an increased chance of having Chiari versus people who aren't related to people with a Chiari. There are a lot of people looking for discrete genes that would lead to this familial predisposition. And so far, although there are a lot of candidate genes, nobody's found one that accounts for most or even many Chiari malformations. Allison Ashley Cook is a real expert in this field. She was a speaker yesterday at this meeting, so she's a really good resource for that sort of a question. I'll tell you my own bias. When you look at the distribution of Chiari in the population, who has it, who doesn't have it, one of my papers was presented earlier showing that the distribution of tonsils in the human population. Now that's a morphometric measurement like any other morphometric measurement you can make in the body. So head size, waist size, height, shoe size, whatever you want to say. Tonsil distribution follows that pattern. So when we talk about people with low tonsils, really low tonsils, that is to say people with Chiari malformation or even symptomatic Chiari malformation, we need to understand that they're on the low symptomatic pathological side of it, what is a normal distribution. What that implies for the genetics is there is almost certainly not going to be one discrete Chiari gene. It just can't be. It doesn't make any mathematical sense. We could find 100 Chiari genes, but I don't think we're going to find one. But practically speaking, with respect to the question that was asked, do you have a risk of passing this on? Well, certainly children of patients with Chiari do have increased risk of having Chiari, but it's not fate. Many children of patients with Chiari don't have a Chiari. And it's certainly not inherited like certain genetic diseases are inherited. That we think of something like cystic fibrosis or something like that. It can't possibly be inherited that way. Dr. Batzdorf is with us now. I'm sure you have some perspective on that as well.
Well, I would agree. I have in my practice a dozen patients where I've operated on parent and child, but I would say overall the myelia incidence in my practice is about around 10% at most.
Okay, thank you. Next question. Where or who do we see about mast activation? Is there a list of doctors? Well, there's one that's on here right now. Dr. Maitland? Dr. Maitland, did you hear that question? Can you hear me?
I can't hear.
Hold on.
No, she can't hear. She indicated that she can't hear.
But you can hear me.
I sent a message. I don't know. Can you hear me?
Yes, I can hear you. Can you hear
We
me?
can hear you.
Okay, I'm not hearing the questions.
Okay.
I'm not exactly sure what the problem
First
is.
was where or who do you see about mast cell activation? Is there a list?
Dr. Maher and Dr. Knowlton, I'm hearing you, but I'm not hearing anything else.
You're not hearing me.
Oh, they asked me to go out and come back. I'll see you in a little bit.
Okay. Can everybody else hear me?
Yeah, I can hear you clearly.
Yeah, I can hear you.
Yeah, I'm starting to get a complex. Before it was my browser. It switched over. Don't ask me. I was on failure film, but it's up. Okay. Let's take another question. Does weight have a direct effect on the searing?
What?
Weight. Your weight.
So that's controversial. There was a paper published in the Journal of Neurosurgery about 10 years ago that claimed that weight was a factor with Syring's formation. I wrote a subsequent paper looking at a much larger population size and found essentially no relationship. So I personally, again, I will acknowledge that it's controversial, but I will give you a simple answer based on my own biases, based on my own studies, and say, no, there's no relationship.
Okay.
I would echo what Dr. Maher just said. In my practice, I don't think that weight is a factor in causing syringomyelia.
You can look at Chiari patients across the entire weight spectrum or the body mass index spectrum and ask the question, who is more or less likely to have a Syring's, and body mass index washes out. It is not a significant factor.
Okay.
Okay, thank you. Where or who do we see about mast activation cells? Is there a list of doctors?
So my suggestion would be to contact the Mastocytosis Society, where they have a list of practitioners, both in hematology, oncology, as well as allergy immunology, who will be able to offer evaluations. And also there's several practitioners who are able to do telehealth visits for the evaluation as well. So.
Thank you. This question's for everybody. Is there a connection between autism, EDS, and CM? I've seen a lot of articles regarding mast cell and autism, as well as Purkinje cells,
Purkinje's.
Purkinje cells in the cerebellum and autism.
So I can comment on one of the lead authors on the New England Journal of Medicine article on mast cell disorders is Theoharides, who's a pharmacologist in Boston. And he actually has been doing mast cell work for more than 20 years and has shown that there seems to be a connection between mast cell dysfunction as well as neurocognitive issues and behavioral issues as well. And now there's a closer association between mast cell dysfunction, connective tissue disorders, and EDS. And we have another link today with the connection of connective tissue disorders with these structural central nervous system and peripheral nervous system issues as well. So there's a growing body of evidence, but I would have to say that's where we are right now.
Okay. Thank you. Are there different strains of marijuana that help with different conditions? If so, is there a particular strain that works best for Syringomyelia and Chiari? What is the best method to take it?
I'm assuming that's for me, Patrice. And as I said when I was presenting, we just don't know. It's very much based on the experience of the patient, and that's what we're hoping to find out with some survey studies, some registry studies we can do to find what people are using, what their practitioners are comfortable with, and what the experience has been. But right now, we don't know.
Okay, thank you. Do Chiari patients tend to have increased symptoms during pregnancy that resolve after birth? That's for Dr. Maher, and anybody else can answer Dr. Batzdorf. But Dr. Maher?
Yeah, well, I'm certain there are lots of Chiari patients out there that have had increased symptoms during pregnancy. And I'm certain that the reverse is true as well. And I'm certain that many people have said that they found that there was no relationship. The fact is, outside of just tiny case series, which is difficult to learn anything from because of the biases that go into decisions to publish and report on things in the first place, it's really difficult to say anything with certainty. So I would say that it's possible for sure, but there's no actual scientific proof that it's a phenomenon that happens with regularity.
Okay, thank you. Why does mast cell issues get so much worse when I'm in the hospital? Hear that, I guess. Why does mast cell issues get so much worse because I am in the hospital? I think Dr. Maitland's frozen.
Yeah, I think she's frozen.
Okay. Okay. What is the best type of MRI? Laying down, standing for Syringomyelia patients? Anybody like to answer that?
I'll take a crack at that. I mean, the majority of patients who MR scan for Syringomyelia have it in the supine position, and I think that's generally sufficient. I think I'll leave it at that for the moment.
Thank you. Can the panel mute themselves when they're not speaking because there's a lot of background noise? Thank you. Okay. What happened now? Wonder Dr. Maitland's not on. Okay. Gwen, contraction be used? Can contraction be used for therapy? What? Contractions be used therapeutic for people with poor CFS flow?
I'm not entirely sure, to be honest, as it's not perfectly my field, but I could speculate that there is a certain amount of, to a certain extent, it's kind of a difficult question. And I would actually be happy to touch on the MRI position question as well, just a bit. I know that right now in my lab, we're doing a study on head down tilt MRI. And so I know that there is some research going on different types of MRI, but the current standard is the supine. And based on what we know, it's going to continue to be the best use as far as we have. We definitely need to work and look into other imaging modalities before we can figure out if there is a better method for actual neck positioning or otherwise. I know that some scans come with longer scan times. And so being in a more uncomfortable position that isn't laying down, things like standing up or leaning back or in a head down tilt position might be uncomfortable for those longer times, which can result in movements. And these movements result in neck angulation that then need to be corrected with post-processing techniques for this movement because of the artifacts therein they present. And so currently being able to be in a comfortable position is the easiest, as the less movement during an MRI is going to be better. But some issues come with that, as in we see that as you're standing, there's a different flow than if you're laying down. And so these slight differences need to be further investigated before we can be sure that a supine position is equivalent to. But as far as what we're using now, it's more than good enough to continue to use the supine. And then if you could repeat the second question for me, that would be really excellent.
Second question.
Yeah, the one that I started responding to. And then moved on to the positioning question on accident.
I'm not sure if it moved, Gwen. Hold on.
So,
I can't repeat it.
can you hear me now?
They already checked it off, so I can't repeat it once
Okay.
I get it.
Apologies.
It's okay.
Hey, Patrice, can you hear me?
Yes, I can. You're
Okay,
good.
just to answer that question regarding why people with hypersensitivity disorders get worse in the hospital, it has to deal with all the chemicals that are used to keep the environment sterilized. And so we're finding a lot of individuals, and even now we're having patients who, students going back to school, there's a concern about the agents that are being used to sterilize the environment to reduce exposure to COVID, but they're actually having hypersensitivity reactions because of the chemical irritants that are being used to sterilize the environment as well. Also, individuals that have mast cell disorders have a tendency not to tolerate some of the tubing that's used for intravenous administration. They're either made with PVC or DHP chemicals. And if you elute off those too fast, you can actually cause direct mast cell degranulation. So there are recommendations that we typically make for IV infusions and also for surgery in order to minimize disturbing the mast cells that are already hyperactive.
Thank you. This is for Dave. Does CBD have any long-term negative effects on the quality of sleep?
That we know of. In fact, we've had people suggest exactly the opposite, that it improves the quality of sleep. The problem, again, I sound like a broken record. You have to get this off Schedule 1 so we can do some research on it. I did want to make a comment, Patrice, on the CBD. Because the federal government released CBD and allowed it to be produced with hemp, a lot of places you can go into a drugstore and buy CBD over the counter, but it does not have the presence of THC, which acts as a catalyst. So it doesn't really work. People claim some wonderful things from CBD alone without THC, and they're probably describing a placebo effect because it just is not active enough to get a clinical response. So everything that I've read and what the research that the Academy of Sciences saw, CBD alone is not going to do much.
Interesting. Thank you. One of Dr. Maitland's slides noted anti-interleukin monoclonal antibodies for MCAS treatment, but didn't say which specific ones. Could she specify which meds are appropriate?
A lot of biologics that are available for dampening either immediate hypersensitivity reactions, that's through the IG receptor on mast cells, as well as delayed type hypersensitivity reactions. So, the anti-interleukin 6, which has been used for some of the rheumatoid arthritic conditions, has been effective with some of the mast cell associated disorders. But I would have to say, before I give a laundry list of which medications are available, you need to kind of identify what kind of mast cell disorder you have. There's a big difference between having a primary mast cell disorder where you have a mutation in either in the c-KIT receptor or any of the signaling molecules, or there's another process that's driving the mast cells to misbehave. So there's omalizumab or Xolair for chronic urticaria and asthma. There is dupilumab, which is an interleukin-4 and interleukin-13 that just got some press in its ability to offer some protection, not only with mast cell disorders, but again, coronavirus patients, coronavirus infected patients seem to be doing quite well on that medication as well. So it all depends on what are the comorbid disorders that might be causing the mast cells to misbehave.
Okay, thank you. Are PCOS, polycystic ovarian syndrome, and hypothyroidism common comorbid disorders with Chiari and Syringomyelia? Who would like to answer that? Anybody?
Not that I know of. I have not heard of this as a comorbidity.
Okay. Why is the 5 millimeter measurement still used as the main requirement for most neurosurgeons to accept a new Chiari patient? You're laughing, Dr. Batzdorf.
Well, there's been much debate about this, and one has to look at this in the historical sense. The original studies that suggested that 5 millimeters was critical were based on what we would today consider statistically inadequate sample. And we have come to recognize, and I think Dr. Maher has already alluded to this, that probably the degree of tonsillar descent is not necessarily related to the severity of the clinical symptomatology, because a lot of things happen that mold the tonsils, and I think one needs to be guided by clinical symptoms rather than focus strictly on a millimeter measurement. I have seen patients who have had less than 5 millimeters of tonsillar descent who have clinical symptoms of Chiari anomaly. I've seen patients who have had more than 5 millimeters of tonsillar descent who are essentially asymptomatic or whose headaches have nothing to do with, in my opinion, Chiari anomaly. So one needs to be a little bit careful, and unfortunately this measurement has entered the literature and it's unlikely to disappear from the literature, but it's only a reference point and certainly not an absolute measurement.
Thank you. Is syringohydromyelia the same as syringomyelia? Dr. Batzdorf?
I'll take that. Well, syringohydromyelia is it's a term invented by radiologists who want to cover their bases, so to speak. I don't like that designation because syringomyelia is a watery, fluid-containing pathological entity. Hydromyelia, in the way in which I like to use that term, is a fluid-containing cavity and can be applied to such things as a residual central canal, but does not imply pathology. So I don't like these hybrid terms because they're invented by radiologists basically to cover their Unowatskis, and they don't really clarify the situation for patients.
Thank you. With all the research coming fast, is it worth it to wait on a surgical intervention if able, because in the next 2 to 5 years, there may be different thoughts or types of surgery? Anybody like to get that?
Cormac, you want to tackle that?
Sure. I really don't think so. If you need surgery now, if you're obviously symptomatic, if you have a big cervical spine searing, probably just have surgery. If you don't need surgery now because you're minimally or not symptomatic at all and you don't have a big cervical spine searing, then you probably shouldn't have surgery. But I wouldn't wait 5 years or even 1 year hoping that something better is going to come along, because frankly, it's very unlikely. I at the risk of being controversial, I sort of disagree with the premise of the question, which is that we're making a lot of progress with surgical interventions. We don't think we are. I think that the most well-accepted operation with the largest amount of evidence for its efficacy has not changed significantly in years. And it seems very unlikely to me that we're going to have a better operation in 2 years or even 5 years. Perhaps that will be wrong, but there's certainly nothing on the radar screen now that seems very hopeful for that. The glass half full way of looking at that, though, is we do have a very good, very effective operation for well-selected Chiari patients. And if you are selecting patients for surgery well, if you're operating on patients who you can predict will do well with the operation, then you can expect very good results, even with the existing operation. So Again, will this be different in 5 years? I think we'll know a lot more about Chiari in 5 years. We've learned a lot in the last 5 years. But one thing that really hasn't changed is the operation.
I would agree with what Dr. Maher said.
Okay. Is the MRI the only way to tell if searings or multiple searings are growing? Dr. Maher, Dr. Batzdorf?
Well, I mean, symptoms matter probably most importantly. So does the patient have new concerning symptoms that could be attributed to the searing? But short of that, yeah, the MRI is the only test we can order that I think would be of any value for the most part, at least in common practice.
Yeah, I would agree.
Dr. Batzdorf, what size of searings is considered large or small, and how much pain patient has most likely associated with the diagnosis of syringomyelia?
Well, that's a difficult question to answer precisely, but I will tell you that in general, the size of the central canal diameter, which I described, is about 3, sometimes 4 millimeters in diameter. And as I indicated, it is completely central and completely round. As far as a pathological syringomyelia cavity, there is no particular size that dictates intervention. It's, again, as Dr. Maher pointed out just moments ago, it's symptoms that the patient has, progression of symptoms that the patient has that should dictate whether intervention is indicated.
Okay, great. When would a myelogram be recommended?
Well, I'll take that question. I think when the site, that is the location, the place for surgery, the point at which the vertebral level should be approached is not clear from the MR scan, a myelogram should be considered. I think that the quality of MR scans today is a lot better than it was some years back, but there are still occasionally cases where I'm not entirely sure that we're dealing with a focal scar, and if in doubt, I have a low threshold for getting the most precise information available today.
How frequently do you see people with the syrinx be managed conventionally without surgery if they do not have progressive or significant symptoms?
Cormac, you want to weigh in on that?
I think we have to make an important distinction here between people with a Chiari and a big cervical syrinx and patients with so-called primary syringomyelia or idiopathic syringomyelia, because I think they can be treated differently. A patient who is even asymptomatic with a large cervical syrinx is very frequently referred for surgery, and in my practice would be a surgical candidate. Not in every practice, but I think it's fair to say that most Chiari surgeons in America today are recommending a prophylactic operation on an asymptomatic patient with a large cervical syrinx. On the other hand, if you have a mid or low thoracic syrinx, you don't have a Chiari malformation, you don't have a tethered cord, you don't have any symptoms, that's somebody who in my practice would never get surgery. They would never get a prophylactic operation just because of the MRI finding of syringomyelia in the absence of any symptoms. So there are cases where you would do prophylactic surgery on asymptomatic syringomyelia, but that would be for the Chiari patient in general, not for so-called primary syringomyelia.
Okay. Is syringomyelia and Chiari patients considered high risk during COVID?
don't know. I have not encountered this particular problem, and I don't know the answer. I don't know that anyone does.
I would echo that same sentiment that we don't know. The evidence from the immunological side states that unless there's some type of underlying innate immune system problem, whether it's the epithelium itself or the immune components that are responsible for the initial response to the virus, then individuals don't seem to be at greater risk. We have seen in the mast cell community that the risk of developing the cytokine storm or the vasculitis that's seen in children, there's no greater increased risk for having the more serious sequela of coronavirus exposure. So.
Okay, and I think this was already talked about. Dr. Maitland didn't really discuss what type of doctors or where we could be seen for mass activation cell. Is there an association or list of doctors, or can all allergy doctors do the testing? And along with that one is allergy doctor who I need to see for mast cell disorder testing? So it's kind of two questions from two different people, but.
So interestingly enough, mast cell disorders have a tendency to be diagnosed either by immunology specialists who like thinking about mast cell disorders, so a good resource, or hematology oncology specialists. So I would recommend the Mastocytosis Society. The website is TMS for a Cure, has a list of practitioners who have stated that they are willing and able to help with the diagnosis and management. As far as testing, there is now, the guidelines have been published not only in the New England Journal of Medicine, but also in the Journal of Allergy and Clinical Immunology, as well as several other hematology oncology journals, to kind of give an idea of what kind of testing is available. Unfortunately, there is difference in availability of testing even from state to state. There's, in New York, for instance, they've only recently allowed the genetic testing for the hyperalpha-tryptophanemia, which is associated with EDS and mast cell, and for the urine metabolites as well. So it's important to kind of use a local practitioner who's willing to work with practitioners who have more experience in that space.
Thank you. I'm going to do 3 more questions, and that's it for today. And the rest of them will get answered online. They should be pretty quick ones. This is for Dave. How do you tell your doctors you use marijuana if they don't know?
If the doctor doesn't know, I assume they mean, yeah. Let me answer that 2 ways. Number one, that's going to depend on who the doctor is and what your relationship is with the physician. Just let me editorialize to say it's important that your doctor know if you're using marijuana, even if you're using it recreationally. It's an important bit of medical data for the doctor. I can suggest I'm not a physician, I'm a psychologist. So I would say you should just tell your doctor straight out, say, this is what I'm trying to, especially if you're using it to mitigate symptoms. It's part of the metric that the doctor should take into account. Maybe the clinical folks here might have a better view of that than I would, but I just want to editorialize that it's important that the doctor know. And one of the reasons that the loosening of regulations on medicinal marijuana is so that people are a lot less shy about sharing with their physician that this is what they're doing. So I think it's important.
Does anybody else want to add anything to that? Okay. Could an infant acquire Chiari from forceps being used during delivery? Dr. Maher?
Well, I like to say that we should never say never and never say always, because it's just never that simple. So I believe it's possible. I also believe it must be incredibly rare. We know that you can get a acquired Chiari from craniosynostosis or skull molding. We know also that the birth process, whether or not forceps are used, can sometimes cause skull molding. Having said that, the part of the skull that needs to be molded for a Chiari tends to be most likely at least the back of the head. We wrote up a case series of that about 10 years ago. And that's the part of the head that's least likely to get molded during childbirth. Furthermore, most neonatal skull molding that results from childbirth tends to self-correct pretty quickly. So again, for all of those reasons, I would say that the scenario that is described in the question must be incredibly rare, but I certainly would never say anything is impossible.
Thank you. When is a syrinx generally aspirated? Dr. Batzdorf?
Rarely, because it used to be done more commonly in the remote past, but basically, if the mechanism for the syrinx to fill is still present, aspirating it as a sole means of treatment is not going to work because it will refill just as soon as the process can take place. So it's not a definitive way of treating a syrinx.
Okay. I think that's it we're going to do for the questions. We're over, and I'm sure you're all tired. So next, the questions will get answered online, and we'll put them up for you. Okay. On behalf of ASAP, I would like to thank all the presenters today. Everyone who spoke today shared valuable information and made a huge contribution in helping our community. Your dedication is very important to us. And on a personal note, I have known most of these specialists for many years. Their skills and generosity and commitment to ASAP has meant a lot. My heartfelt thanks to all of you. I really appreciate it.